Welcome back to the deep dive. So today we're opening up a file that's you'd think would be pretty dry. It's about thyroid surgery. But I have to say, once you start reading through these surgical guides and the history, it's really something else.
No, not at all. It's surprisingly dramatic.
It reads more like a bomb disposal mission, but, happening inside the human neck. We're talking about a workspace maybe the size of a coffee cup,
That's a great way to put it.
where millimeters, literally millimeters, separate a cure from a total catastrophe.
And that's the whole game. The thyroid is this butterfly-shaped organ, and it's draped right over your windpipe. The problem is it's in what I would call the most expensive real estate in the entire body.
So crowded in there, you've got the airway, the carotid arteries feeding your brain, and all these microscopic nerves that control speaking and breathing, all tangled up.
Like spaghetti, yeah.
So our mission today is to unpack this decision matrix surgeons use to navigate that minefield. We'll look at the actual triangles they map out to avoid disaster, and we're going to talk about why one tiny piece of tissue called Barry's ligament is basically the final boss battle of neck surgery.
It is, and it's a battle that has changed completely over time. I mean, to really appreciate the precision we have now, you have to understand the absolute carnage of where this all started.
The dark ages of the thyroid. Yeah, the source material paints a pretty grim picture of the 1850s.
Grim is being polite. Back then, if you had a goiter and enlarged thyroid surgery was the last thing you wanted, we're talking about a 40% mortality rate.
Which is basically a coin toss.
Worse than coin toss. And even if you survived, you were likely maimed. Surgeons in the mid-19th century were fighting two invisible enemies. Sepsis, this is pre-germ theory, and hemorrhage. The thyroid is just incredibly vascular.
The texts describe it as uncontrolled bloody flux. Sounds like a horror movie. Surgeons would cut in, blood just obscures everything.
And they're operating blind. It was considered a do-not-touch zone. The French Academy of Medicine actually banned the procedure.
They banned it.
They did. It was forbidden ground. It was malpractice to even try because the patient would almost certainly bleed out or die of infection. That's our starting point. Until Theodore Kocher comes along.
The protagonist of our story.
Theodore Kocher is the reason we can do this deep dive without it being a tragedy. So he's operating in Switzerland in the late 1800s, and you have to understand that geography Switzerland is landlocked, so back then the soil was iodine deficient.
So goiters were everywhere.
Endemic. Everyone had them, which meant Kocher had this endless supply of massive complex cases to practice on.
But he didn't just practice, he revolutionized the whole thing.
Yeah.
He took that 40% mortality rate, and by 1898, he had driven it down to, 0.2%.
It's a logistical miracle. Going from 40% to 0.2 in a single career is just, it's unheard of.
So how do you do it? Better tools.
It was a change in philosophy. He focused on obsessive, meticulous hemostasis. He realized you couldn't just slash and grab, you had to tie off every single vessel before you cut it. He figured out how to ligate the inferior thyroid artery cut off the blood supply at the source.
Turn off the faucet.
Exactly. He turned a bloody mess into a clean, dry field where he could finally see the anatomy.
And that visual clarity led to a Nobel Prize. But this is the part that blew my mind. It wasn't just for the surgery, was it? It was for what happened after.
This is a great irony. Kocher got so good at removing the whole thyroid safely that his patients started surviving the operation. But then, months later, they started deteriorating.
This is the condition he called cachexia stroma priva. Sounds like a magic spell.
The symptoms were devastating. His patients became sluggish, mentally slow, physically swollen. Their metabolism was crashing. He realized that by removing the entire gland, he had removed something vital.
He discovered what the thyroid actually did.
He did. Before Kocher, people thought it was just padding for the trachea. He won the Nobel in 1909, not just for being a great surgeon, but for linking an organ to its function to endocrinology.
And that knowledge comes over to the U.S. with guys like Halsted, who trained the founders of the Mayo and Crail clinics. But let's jump to the modern OR, because even with all our tech, the anatomy hasn't changed. It is still a minefield.
And the way modern surgeons handle that is through geometry.
This was my favorite part of the reading. They map the neck into triangles. It feels like celestial navigation for anatomy.
It has to be structured. You can't just dig around in the neck. You need boundaries. You need to know, if I stay in these lines, I'm safe.
Okay, let's walk through them. First up, Joel's triangle. That's at the top of the gland. What are we hunting for here?
In Joel's triangle, you are hunting for the external branch of the superior laryngeal nerve, the EBS-LN.
Or the singer's nerve.
Precisely. This tiny nerve controls the cricothyroid muscle, which is what tenses your vocal cords. It's like the tuning peg on a guitar string. Lets you change pitch, hit high notes.
The source material had this great vignette. A patient wakes up and says, "Doc, I can talk fine, but I get tired reading a bedtime story," or "I can't shout for my kids." That's the EBS-LN.
That's the classic presentation. It's not a lost voice, it's a weak voice. You lose your dynamic range, your stamina, and because that nerve runs right next to the superior thyroid artery, it is incredibly easy to accidentally clip it.
So Joel's triangle is the map to avoid that. You stay within the lines, you find the nerve before you clamp anything.
Identify before you ligate. The golden rule. You have to see it to save it.
Okay, moving down the neck. Bear's triangle.
This is the main event. Some call it the triangle of concern. It's where you go to find the big one, the recurrent laryngeal nerve, the RLN.
And this one controls the actual movement of the vocal cords, right? Opening and closing.
Right. The stakes are much higher. You damage the singer's nerve. You might ruin a career. You damage the RLN. You can ruin a life. Unilateral damage gives you a horse whisper, but bilateral damage cutting both of them.
No, that's bad.
The cords flop shut. You can't breathe. That's a permanent tracheostomy.
And the name recurrent is because it takes this crazy detour.
A huge detour. It drops from the brain, goes all the way into the chest, loops around the aorta on the left or the subclavian artery on the right, and then comes back up, recurs into the neck.
Seems like a design flaw.
It's an evolutionary artifact. As the fetus develops, the heart descends and just drags a nerve down with it.
But that dragging action creates a rare but terrifying trap. The non-recurrent laryngeal nerve.
The anomaly happens in about 1 or 2% of people, almost always on the right side. In these folks, the nerve didn't get dragged down. It comes straight out of the vagus nerve and shoots right into the larynx.
So imagine you're the surgeon. You're in Bear's triangle, looking for the nerve where it's supposed to be, coming up from the chest, and it's not there.
That is the detective moment. If you're digging in the normal spot and you don't see the white flash of the nerve, you have to stop immediately. Because if you keep going, you might cut the non-recurrent nerve, which is sitting higher up, totally exposed.
Amazing. Yeah. Now, let's say you found the nerve. You still have to free it. And this brings us to the boss battle. Barry's ligament.
The danger zone. This is where the room gets quiet.
Why is this one spot so notorious?
Because of the texture. Barry's ligament is dense, fibrous tissue that anchors the thyroid to the windpipe. It's tough. But the recurrent nerve, which is soft, fragile, like wet tissue paper, often runs through it or is plastered right underneath.
So you're cutting through tough stuff to save the soft stuff, and they're glued together.
Exactly. And you can't use electric cautery here because the heat will travel and fry the nerve. You have to use cold steel, a sharp scalpel, and dissect millimeters at a time. It's all about traction and counter traction.
It sounds incredibly stressful.
It's the moment in the surgery where the music goes off and everyone just focuses.
So we know how to cut safely, but there's a whole section on what to cut. The strategy. Apparently we don't just take out nodules anymore.
Right. The old nodulectomy, just popping out a lump, is dead. Totally abandoned. It's messy, it's bloody, and you leave tissue behind that can grow back. And if you have to go in for a second surgery, the scar tissue just ruins everything. The risk of nerve damage goes way up.
So the rule is, do it right the first time.
Correct. The minimum modern standard is a total lobectomy. You take the entire half of the thyroid, it's clean, safe, and if the nodule is benign, you're done.
But then there's the big debate. Lobectomy versus total thyroidectomy. Half or whole.
It's a logic tree. If it's a single benign nodule, you take half. The patient might not even need pills. But if it's Graves' disease or a goiter where the whole gland is sick, you take it all. You don't leave disease behind.
What about the indeterminate nodule, where the biopsy comes back as a maybe?
That's the gray area. Usually a surgeon will do a lobectomy first as the final biopsy. If it's cancer, they can go back later. But the sources note a shift. If the patient has a lot of risk factors, some surgeons just go straight to a total thyroidectomy to avoid a second operation.
Okay, speaking of risk, let's talk complications. We talk nerves, but the number one permanent complication isn't vocal cord paralysis. It's hypocalcemia.
Low calcium. Which brings us to the parathyroid glands.
4 tiny glands, the size of a grain of rice, hiding behind the thyroid.
And they share the same blood supply. That's the problem. When you're tying off arteries to remove the thyroid, it is very easy to accidentally strip the blood supply from the parathyroids.
And when they fail, calcium plummets. What does that feel like?
It's visceral. Calcium stabilizes your nerves. Without it, they get hyperexcitable. The first sign is usually tingling around the lips, perioral paresthesia, then fingertips. If it gets worse, their hands can lock up in a painful cramp.
The sources mention Chavosteck sign.
The cheek twitch. Yeah, you tap on their facial nerve and their face just twitches uncontrollably. It's a classic sign.
And the fix is just calcium.
Usually IV calcium gluconate if they're symptomatic. Most of the time, the glands are just stunned and recover. But if you accidentally removed all 4, that patient is on calcium for life.
Now, there is one complication the sources treat with absolute urgency. The airway nightmare. The expanding hematoma.
This is the one that wakes surgeons up at night. This is the true emergency.
So surgery's over, patient's in recovery, then a vessel pops.
And the neck is a closed space. So when blood fills it, the pressure builds and it has nowhere to go but inward, crushing the trachea.
The windpipe.
Exactly.
And the protocol here goes against every instinct. The instinct is rush to the OR.
And the source says, wrong. If you wait for the elevator, wait for the team, they will die. The airway will collapse.
So what's the move?
Bedside evacuation, right there in the recovery room. No sterility, no waiting. You grab a staple remover or a scalpel and you rip the incision open.
You open the wound right there in the bed.
You have to. You scoop the clot out, the pressure releases, the trachea springs open, and the patient breathes. Then you go to the OR to find the bleeder. It's messy, but it saves their life.
Life over sterility. That is intense.
Like the mindset.
The sources had some trap questions too for board exams. Let's try one.
Go for it.
Okay, patient is 6 hours post-op. They develop stridor, that high-pitched wheezing sound. What is it?
The trap is to say recurrent nerve injury, but nerve injury is immediate. You'd hear it right away. Stridor developing hours later. That's a hematoma. The airway is collapsing. Open the neck. Now.
Scenario B. Patient is hoarse immediately after waking up.
Okay, that sounds like a nerve injury. But
Yeah.
did you check the cords before surgery?
The pre-op laryngoscopy.
Exactly. It's the cover your bases rule. A lot of people have a pre-existing vocal cord issue they don't even know about. If
Yeah.
you don't document that before you operate and they wake up hoarse, you own it. Legally.
That is a crucial detail. Before we wrap, let's hit the inside baseball section, the little nuances.
The craftsmanship.
First, the north-facing tube.
It's so simple. The anesthesiologist tapes the breathing tube so it points up, north, over the forehead.
Why?
Space. The neck is small. You don't want tubes and tape cluttering your field. It gives you a clean canvas.
Then there's the iodine rule,
This is for cancer cases. You never wash the wound with betadine, which is iodine.
because the thyroid loves iodine.
Exactly. Thyroid cells absorb it. If there's any cancer left, you might want to treat it later with radioactive iodine. But if you soaked the area in regular iodine, those cells are already full.
So the radioactive treatment won't work.
They won't take it up. You've blocked your own treatment, so saline only.
And finally, the Valsalva maneuver,
Yeah.
the last check.
The stress test.
Yeah.
The field looks dry. You ask anesthesia to squeeze the bag, which increases pressure in the chest and swells the veins in the neck.
Like straining to lift something heavy.
Yep. If there's a loose tie or a small vessel that clotted, that pressure will pop it open. You want it to bleed now while you can see it, not 10 minutes later in recovery.
It's incredible. Every single step, from the tube placement to the triangles to that final check, is all designed to mitigate risk.
It really is, and that's the synthesis here. We started with the bloodbaths of the 1850s, moved through Kosher's obsession with a clean field, and we arrived at this modern geometric art form.
A procedure where knowing your anatomy, respecting Barry's ligament, finding that Singer's nerve is the only thing standing between the patient and a disaster.
I think that's the main takeaway. When you look at the thyroid, you're seeing a responsibility. The difference between a patient who can speak clearly to their grandkids versus one who has to whisper forever. That often comes down to a few millimeters of dissection, or recognizing a 1% anatomical variant.
It's a sobering thought. Knowledge here isn't just power, it's safety.
It's someone's quality of life resting on the tip of your scissors.
A fascinating look into a world most of us hope to never see from the inside. Thanks for walking us through it.
My pleasure.
And to you listening, thanks for diving deep with us. Stay curious, and we'll catch you on the next one.